There are a number of special challenges with pediatric patients versus our adult patients. It's harder to get a history from kids if the parent, the guardians aren't around to get history from. It's just more difficult to get information from the kids, even the ones before they learn how to speak, right? And then as they get older, they may be afraid to talk to you or just scared of the situation. Just anxious about the situation in general, right? And there's always the chance that those there to who are supposed to be there for the child are hiding something from you. So some unique challenges when dealing with our pediatric population. I heard this one's from a pediatrician, and I like it. They likened it to veterinary medicine, so just kind of this veterinary approach to patient assessment, because pediatric patients, just like my dog here at home, can't really articulate what's going on, exactly what's wrong. They may be able to tell you they have belly pain, but or their belly hurts, but other than that, it's kind of hard to get information out of them, just like a dog, right? A dog can't tell you exactly what's wrong with it. So we're looking at signs and taking in kind of all this information that we're collecting on the pediatric patient, and try not to go straight to a diagnosis like we would in adults. Presentations can be different in children and be more vague, or just a completely different combinations of signs and symptoms versus adult patients. Big thing to keep in mind, pediatrics usually have a respiratory issue going on. That's usually their primary issue going on. For adults, it's more frequent to be a cardiac complaint, so pediatrics always be thinking respiratory first. And for assessment, our primary assessment of the pediatric patient, we're going to follow this pediatric assessment triangle, in which we're looking at their appearance, what's their mental status like, what is their muscle tone like. We're looking at skin signs for circulation, and we're looking at their work of breathing, their respiratory rate, and their respiratory effort. So that's going to be our primary assessment of our pediatric patient. And shock is going to look different in your pediatric patients. So here's some kind of guidelines on normal systolic pressure. So if they're under these benchmarks here, we're thinking hypotension. Children can easily go into shock. So as the child grows older, obviously their baseline blood pressure is going to rise as well. But under these benchmarks here, we're going to be thinking shock. Now let's talk BRUI, if you've heard it pronounced both ways, but brief resolved unexplained events. Used to be called ALTEs, apparent life-threatening events, but now we've got these brief resolved unexplained event. And what is it? Well, it's an event that was brief, it resolved itself, and we don't know why it happened. So it's brief resolved unexplained event. We see it in infants. And there's this acute change in breathing and appearance and behavior, usually lasting less than a minute. It resolves itself. By the time we get there, the baby is completely normal, but that brief resolved unexplained event has taken place, so we need to document that and need to follow up with medical care. And this is not to be confused with SIDS, so this is separate from SIDS. Some characteristics of these brief resolved unexplained events. Again, we said changes in breathing, maybe apnea or struggle, some sort of skin color change, and then changes in muscle tone, going limp, or choking or gagging sounds, along with that altered level of responsiveness. After lots of research, the majority of these events have been found to be due to some sort of reflux, some GI reflux, or these are the early diagnostics for neurologic episodes, seizures. If they've got epilepsy, this might be a precursor to that diagnosis, or they've got some sort of brain bleed or stages of infection. Cardiac disease or cardiac events are less frequent reasons for these events, as are just upper airway obstructions, or other disorders. And always with our children, we're never going to forget child abuse and child abuse as a cause of one of these events. We said that BRU is not SIDS. So what is it? Sudden infant death syndrome. SIDS, leading cause of mortality, ages 1 month to 1 year in the United States. And we have a determination of SIDS when no cause of death can be determined on autopsy or after this event. Since recommending that children sleep on their back, we've seen a 50% drop in SIDS deaths. So many causes to SIDS. One of these may have been respiratory issues with different sleeping positions. So just a 50% drop in SIDS just by having your baby sleep on his back. Risk factors for SIDS, exposure to cigarette smoke in the home is a big one. Young mothers, so maternity age less than 20, we've seen that be a risk factor for SIDS, along with premature birth. And then environmental, are they sleeping prone? Do they have soft bedding? Or are they overheating overnight? So BRU versus SIDS side by side. BRU may range from just benign changes to near fatal, while SIDS is a fatal event. And 80% of SIDS deaths occur between midnight and 6 a.m., so overnight, while 82% of BRU events occur during the day, 8 a.m. to 8 p.m. So different interventions have lowered cases of SIDS, while there's been no change in the overall cases of BRU. Alright, next up, let's talk pediatric respiratory conditions. Upper airway obstructions are common with children. They've got smaller airways. It is easy to get something stuck in there, and this can progress very quickly. Causes of upper airway obstruction could be a foreign body, often is a foreign body, but also think infections, think epiglottitis and croup, things like that. Any burns or trauma, and then allergic reactions and anaphylaxis, all causes of upper airway obstructions. Epiglottitis is, of course, swelling to the epiglottis, and that will cause an obstruction above the vocal cords there. Typically very rapid onset, and epiglottitis itself has seen a big decline since we've had type V flu vaccines. So here we can visualize that enlarged epiglottis causing a partial obstruction there in the airway. And if you go down with the scope, you'll see big old, just enlarged, inflamed epiglottis. Then we've got croup, which is another swelling, but it's below the vocal cords, and it has this very characteristic barking cough. Croup is viral, can be mild, can be life-threatening, and it's most common in patients between 6 and 36 months, although you can have older children experiencing croup. So one against the other, epiglottitis, it's going to be the obstruction above the glottis, while the croup obstruction below that glottis. Croup affects more younger children, while epiglottitis affects more older children. And epiglottitis, usually flu virus, while croup is also viral, just not specific to that type B flu virus. Foreign body airway obstructions, very common in children, especially younger children, toddlers, and older infants. Usually their first thought is, when they see a new thing, is, what is this? Their second thought is, what does it taste like? They shove it in their mouth, and we get a foreign body airway obstruction. So if you can see it, grab it out. If not, we'll follow AHA protocols for clearing airway obstructions in infants and children. Now let's talk altered mental status in children. So altered mental status, we need to know what the child is like at baseline, and are they acting age appropriate? So depending on their age, are they acting appropriate for that age? A 1-year-old is going to be a little bit different than an 8-year-old, right? So are are they altered based upon their baseline? And really, first thing we're going to think about here with altered mental status in kids is infection. Infection very common and can lead to decreased mentation. Also, think ingestions, accidental ingestions, overdoses, deliberate ingestions. And then if a child has not yet been diagnosed with diabetes, this might be one of the first steps towards diagnosis there. Also ask the parents, guardians, whoever is in their care, anything congenital, anything genetic or structural that may be causing this alteration, and then of course trauma. With newborns and infants, remember that they have this immature immune system. They're more prone to infections, and we need to be asking about anything congenital. Was their delivery normal, everyday delivery, and being on the lookout for trauma, because remember, not everyone finds a crying kid adorable, and we always have to be keeping an eye out for child abuse. With these patients and assessing altered mental status, we're looking at what is their baseline, are they acting age appropriate, and what does their general state look like? What's their cry like? Is it strong? Is it weak? What are their eating and drinking habits been like? What are their sleep been like, sleep schedules, and then your vital sign assessment. What's their respiratory effort like? What's their pulse like? What's their muscle tone like? And what's their skin look like? All right, let's hop on over to meningitis. So meningitis, look out for signs of infection, and then we've got these central nervous system changes. We've got this lethargy, maybe comas, confusion, irritability, nausea, vomiting, headaches if the child is old enough to complain of it, but they're going to have some sort of alteration in their mental status, right? That nuchal rigidity, the neck pain, the stiff neck might not always be present, or not present at first, so we need to look for other signs of meningitis and infection. Another cause of altered mental status would be seizures, so we need to ascertain and assess this patient and whether or not these seizures are, I don't want to say normal, but they've already been diagnosed. Maybe this is the first step towards an epilepsy diagnosis for this child. So is it congenital? Is it not? Is there an underlying illness, an underlying infection? Is there trauma present? So we need to find the source of the seizure. And febrile seizures are our most common pediatric seizure that we're going to see. So usually between 9 months and 5 years, give or take, and associated with underlying illness. Typically, it's a viral infection that leads to these. So the seizure, it's a febrile seizure, but it occurs because of a rapid change in temperature, not because of the temperature itself. So it's not as if you're going to have a febrile seizure once your temperature hits 103 Fahrenheit, right? It's the rate in which the temperature increases. So that sudden temperature increase is going to trigger these febrile seizures. For febrile seizures, that doesn't mean that the child will develop epilepsy or seizures later in life. Doesn't even mean that the patient, this child, will have a seizure ever again in their life. But research has shown that they do tend to cluster within families. So you might just be kind of genetically predisposed to febrile seizures. But long-term wise, this is not a long-term diagnosis. Doesn't mean you're ever going to have a seizure again in your life. Okay, let's move over to the cardiac side for pediatric patients. For cardiac conditions, as the child grows up, these cardiac issues will show themselves, will manifest, and they're going to predominantly be arrhythmias, dysrhythmias. For these arrhythmias, we'll break it out very broadly into two categories. First off, bradyarrhythmias. If you see a slow heart rate in a child, these are almost always pre-arrest rhythms, and almost always due to hypoxia. So jump on the oxygen, the aggressive oxygenation first, and be ready for this child to arrest in front of you. On the other end of the scale are tachyarrhythmias, are just these abnormal rapid heart rates. can manifest as SVTs, can be VTAC, and easily lead to shock in pediatrics. Our threshold for SVT is going to differ a little bit depending on age. With infants, anything greater than 220, we'll start thinking about SVTs. As a child grows older, we'll shift that number to 180 per minute. Then we have the phenomenon of commodia cordis, in which one is hit in the chest right over the precordium, and it's hit just at the right time during our cardiac cycle, causes R-on-T phenomenon. So I've got my T wave, and just as my T wave is peaking, I get struck in the chest and causes a little extra electrical burst to get this R-on-T, throws me into a ventricular rhythm. Common, or I should say common in children, but we do see it in children, especially playing sports. They're playing baseball, get hit by a line drive, or playing football, playing hockey, they get hit in the chest. Just the right time, it will throw them into a cardiac arrest rhythm. Let's keep moving forward and talk about pediatric resuscitation. Now, under pediatric resuscitation, sometimes it's delayed to inexperience of the provider, and inexperience and just or inability to recognize the severity of the child's current condition. And sometimes we don't want to be too aggressive with children. We kind of hold back a little bit with aggressive treatment because we don't want to quote-unquote torture the kid. We want to make it a good experience, this interaction with healthcare personnel, but sometimes we do need to be aggressive in our treatment just like we would with an adult. Here's what the AHA has to say about pediatric resuscitation. First off, with bradycardia, if they are bradycardic and there's some sort of cardiac compromise or symptomatic, we are starting CPR if the heart rate goes below 60. So remember that a low heart rate, that is bradyarrhythmias, we might need to start CPR compressions and aggressive oxygenation, even if they still have a palpable pulse. So starting with CPR, starting with aggressive oxygenation, and then later on moving into our medications. Then if the child does go into cardiac arrest, we'll go down our cardiac arrest protocols. If it's shockable, we're going to go ahead and shock it. We're going to go ahead and give antiarrhythmics. If needed, we're going to give epinephrine. And we're going to follow our cardiac arrest algorithms here from AHA. For tachyarrhythmias, it depends if it's the complex is wide or narrow, whether or not they're symptomatic or presenting in shock. So we can think about synchronized cardioversions. We can also think about adenosine in these patients, and it just depends on the presentation of your patient. And when we say that it depends on the presentation of your patient, remember that kids have this propensity. They will compensate all the way until they are finished compensating. So they compensate and they look all right, and then they completely fall off the edge. So there's no trending downward like you'll see in adults, these compensated shocks. They will just compensate, and then there's no middle ground before they are completely decompensated. And for pediatric resuscitation, we are going to be aggressive in our treatment, but appropriate. We're going to hope for the best, but expecting the worst. And with that pediatric patient who's been compensating perfectly the entire time, we want to be mindful that they could completely decompensate in front of us very quickly. And we'll always have on hand a cheat sheet like Hand Heavy or a Broslow tape. And these cheat sheets and these Broslow tapes gives us a handy guide for common medications and resuscitation procedures that we will need to provide without us having to flip through a lot of books, do a lot of math right there in the moment. So these cheat sheets go a long way. Let's end this up talking about a couple of pediatric scoring mechanisms. One is a pediatric trauma score. So you've got a pediatric trauma patient. We're going to calculate this pediatric trauma score. Any score under an 8 will definitely require a pediatric trauma center and a specialty hospital. Then if you're lucky enough to get that newborn, remember we are calculating APGAR scores at least at 1 minute after birth and 5 minutes after birth. You can continue it on after that, but those are the two primary ones. Just need to, or would like to refresh on APGAR. There are 5 categories. Each category either gets 0 points, 1 point, or 2 points. So the overall score goes from 0 to a 10, with 10 being perfect. And of course, if you have any questions, please let us know.